Hi, and welcome to the August 2026 DermSurgery Digest podcast. I'm the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Rapid Pearls segment focused on Mohs, cancer, and reconstruction, we have Sydney Proffer, a private practice Mohs surgeon in Austin, Texas, doing the in-depth article summaries, and Erica Lee providing clinical applications and tips. Don't forget that we will continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery, but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Welcome to the August DermSurgery Digest podcast Rapid Pearls episode. My name is Sydney Proffer, and I'm a board-certified dermatologist and Mohs surgeon in Austin, Texas. Today's featured expert is Dr. Erica Lee. Dr. Lee, would you please introduce yourself?
Hi, Sydney. Thank you for having me. I'm also a board certified dermatologist and Mohs surgeon, but I am based in New York City, New York.
Perfect. This episode will feature quick article summaries and Dr. Lee's rapid pearls from articles published in the August issue of Dermatologic Surgery. Our first communication article is Basal Cell Carcinoma Arising in a Congenital Apocrine Nevus by first author Cheyenne Hornback and senior author Mary Maloney. Most dermatologic surgeons will never encounter a pure apocrine nevus, making this month's case report both educational and memorable. Apocrine nevi are exceedingly rare congenital hamartomas composed of mature apocrine glands, with only a handful of cases described in the literature. They most commonly present as stable scalp nodules with focal alopecia and are generally considered benign. The authors describe this case of a 39-year-old woman with a lifelong scalp birthmark who developed superficial basal cell carcinoma within the lesion. Mohs micrographic surgery cleared the basal cell in 2 stages, and histopathologic examination of the debulk specimen revealed underlying congenital lesion to be a true apocrine nevus rather than the more familiar nevus sebaceous. Remarkably, this represents only the second reported case of basal cell carcinoma arising within a pure apocrine nevus. For dermatologic surgeons, the clinical lesson is more straightforward. While pure apocrine nevi themselves rarely require treatment, any congenital lesion that demonstrates new clinical change warrants a biopsy. Histopathologic distinction from nevus sebaceous is also important because these entities differ in their composition and also associated neoplasms. When malignancy develops, Mohs surgery or complete surgical excision provides definitive treatment. Ultimately, this unusual case serves as a reminder that even exceedingly rare congenital lesions can harbor secondary malignancies, reinforcing the importance of maintaining a low threshold for biopsy. Dr. Lee, I have never seen this entity in my practice. What are your takeaways from this article?
Well, I have to second you because I have not seen it either. And this is a great reminder that, there are so many different congenital lesions that patients can present with. Basically, it's a good reminder that if you have something on anyone that's congenital, that there can always be a small chance of malignant transformation. The reassuring thing about the lesion and this case report is that the more common one that we see is the nevus sebaceous, right? And I've seen definitely nevus sebaceous or ones that are sort of on the spectrum of nevus sebaceous, like it may have features like, I think, more like an apocrine nevus, but it hasn't been fully a nevus sebaceous, so it's sort of like a spectrum. But the reassuring thing about these lesions is that these are typically superficial and not aggressive skin cancers, right? So they're basal cells. The patient that I recall was on the scalp as well, and she would have superficial squamous, like she would develop in situs within her congenital nevus. So the reassuring thing is that despite the fact that they can have malignant transformation, they tend to be more of the basal and the squamous type. And for these lesions, Mohs is really the best approach. You can also see on the frozen sections the background nevus, which I think is really a great way for us to do the correlation and ensure that we are just removing the malignant tumor and not the whole nevus. So this again, what's great about these articles is you may never see them, but now that you have this article, we've all now aware of it. And this might be the only time we ever see this as a whole for a lot of the readers. But we see a lot of hematomas, follicular hematomas, and being able to distinguish them underneath the microscope is important. But I also think what the authors did here is that if you ever encounter something like this and you don't know what it is, sending the tumor debulk really has a lot of value because it answers both questions. Like you're able to figure out what something is, and really be able to kind of complete the whole story. So it's a very great little case report, and just a reminder that anything can develop, but the Mohs is a great approach to taking care of it.
Perfect. Our next communication article is Hyperbaric Oxygen Therapy as a Treatment for Post-Operative Complications Following Mohs Surgery, a survey study of American College of Mohs Surgery members, by first author Trinh Nguyen and senior author Stephanie Cullison. Hyperbaric oxygen therapy is an FDA-approved treatment for several post-operative complications relevant to derm surgery, including compromised grafts and flaps, delayed radiation injury, and chronic non-healing wounds. Despite its potential, the survey of American College of Mohs Surgery members found that hyperbaric oxygen therapy remains significantly underutilized. Among 63 responding surgeons, nearly half could not identify a single approved indication for hyperbaric oxygen, and only 37% felt comfortable explaining this therapy to patients. Almost two-thirds recognize that hyperbaric oxygen may have a role in managing postoperative complications, but only 14% had ever referred a patient. The most common barriers included limited knowledge, uncertainty about insurance coverage, unfamiliarity with local hyperbaric centers, and unclear referral pathways. Encouragingly, more than 70% of responders expressed interest in additional education, and prior exposure to hyperbaric oxygen therapy lectures was associated with significantly greater knowledge. Although evidence specific to Mohs remains limited, hyperbaric oxygen may offer another option for carefully selected patients with compromised flaps, grafts, radiation injury, or even difficult wounds. This study highlights an important educational gap and underscores the need for larger clinical studies to better define which patients are most likely to benefit. Dr. Lee, how do you counsel patients surrounding hyperbaric oxygen therapy? Is this something that you utilize or recommend or refer patients for in your practice?
So that's a great question. So I do not routinely recommend hyperbaric oxygen, and I think a lot of it has to do similar to what the survey showed, that there is not a lot of knowledge about this. There isn't a lot of information that I'm aware of that we know about insurance coverage. But as Mohs surgeons, we have such a plethora and a huge armamentarium of all the different repairs that we can do. So even if you have a complex wound, we are trained and able to do flaps, grafts. There are now skin substitutes. So really, there's such an array of different wound care options that for the vast majority of Mohs surgeons and defects, the patients are able to be repaired and then they can heal. It could take a while, but they can heal. Whenever I think of hyperbaric oxygen, I tend to think of it for those who need chronic wound care, and they go to a wound care center. So I feel like those patients who go to a wound care center for these chronic wounds from like diabetic or chronic venous wounds are, for example, one group of patients that may benefit. And I do recall having a patient who did have hyperbaric, unrelated to what we treated her for. And it was more for sort of like the skin necrosis from radiation on an extremity. And I do think that was it did benefit them in the long run to help them expedite the healing. So, there is probably a role in hyperbaric for a very small select group of patients in our world, but I do think for me to recommend it, I would have to see it. I think you would have to sort of pair up with the wound care center and really start to understand what it is, because a lot of our patients come to us and they really value what we recommend and advise them. And I think for us to do that, you have to be pretty well educated in what it is as well. So this gives us a good sort of overview that there is a gap. And I do think there is possibly a small role in hyperbaric, but it has to be probably for a very, very select group of patients.
Yeah, I would agree with you. I would think patients that have those underlying risk factors or comorbidities like diabetes or chronic lipodermatosclerosis, and you're
Exactly.
doing a
Yeah.
Mohs case on a leg, a shin, or an ankle or something like that, that maybe you would consider it. But I thought it was interesting. I identified with a lot of the factors that they
Yeah.
highlighted in the article of the knowledge gap there. So I think if our listeners have any additional information, I definitely I need to learn more about hyperbaric oxygen, and I agree with you. I think that there's for a certain subset of patients it could be useful, but we need to learn more about it.
Yeah, no, definitely, like you said, the lipodermatosclerosis patients, I think, if you have these EBA patients, or if you have like
Mhm.
chronic GVHD or radiation, like all sort of those patients, and you've tried a lot of different options for healing and it's not there, I think hyperbaric is probably something to consider. But there is a gap, and I do think lectures and having more exposure to it would help before we start making the recommendations.
Perfect. Our next article is Acquired External Auditory Canal Stenosis After Mohs Micrographic Surgery, Prevention and Use of an Expandable Earwick by first author Miranda Tomorares and senior author Joshua Owen. Reconstruction of the external auditory canal presents a unique challenge for Mohs surgeons, as postoperative scarring can lead to acquired external auditory canal stenosis, a complication that may cause conductive hearing loss, chronic drainage, cerumen retention, or difficulty using hearing aids. In this practical review, the authors highlight a simple intervention borrowed from ENT that may help prevent this complication after Mohs surgery. The risk of stenosis is overall greatest when surgical defects involve 50% or more of the external auditory canal circumferentially, where exposed canal surfaces can heal with granulation and excessive fibrosis. While skin grafting can reduce scar formation, the authors emphasize that the additional value of postoperative canal stenting for 7 to 10 days. They recommend an expandable earwick, a readily available hydroxylated polyvinyl acetate sponge that expands with otic drops. And in this study, they use ciprofloxacin and dexamethasone to maintain canal patency while simultaneously delivering these topical medications. Compared with traditional gauze packing, earwicks are less abrasive, retain the eardrops medication more effectively, and provide consistent support to healing tissues. The wick should be inserted approximately 2 centimeters into the canal, extending beyond the surgical defect, followed by antibiotic and corticosteroid otic drops. Patients should also be monitored closely for early signs of stenosis, including otorrhea and hearing changes. Although evidence specific to Mohs surgery remains limited, this inexpensive and accessible technique represents a valuable addition to our reconstructive toolbox that may help preserve canal patency and long-term hearing outcomes. Dr. Lee, could you see yourself utilizing something like this in your clinical practice? And tell me what you do for tumors that track down into more of that cartilaginous component of the
Yeah.
external auditory canal.
For sure. So, when we have these tumors, especially if they start like in the concha bowl,
Mm-hmm.
and it could be an infiltrative or like a micronodular basal cell, it's really common for it to kind of start tracking into the EAC. And definitely, like every attempt should be made to make sure you get all the tumor out, especially in those hard to reach places. So if I do have a tumor like this and we've cleared it and it's tracking in, obviously everything, that I can access, I will remove. If there's ever a point that I feel that it's not within my reach, then we will sort of consult with our ENT colleagues for assistance in kind of clearing that inner border. But I will always try my best, if possible, to do some sort of graft, like a full thickness skin graft, as far as I can to get into that part of the EAC canal, because for the reason of the stenosis,
Mm-hmm.
right? Because you really want to minimize that from happening. And if we do end up doing that and we're able to do a skin graft, then I often like to use even just like a simple dental roll that we sort of leave in that area, for like a week or so. It's a little bit uncomfortable because, again, anything that's expandable, whether it's this wick or something else, is going to lead to the hearing to be blunted in that ear. But it's also great because it can also kind of like track up or drain any kind of fluid that comes up. And it prevents it from going into the ear canal. So anything simple like that. But the wick it's a neat little way to do it. I like how the fact it's expandable. So it
Mm-hmm.
kind of expands probably to the shape of the ear. And it's not expensive. So that's like the big part, I think, is you want to keep in mind that it's not that expensive, it's easy to use, and it sort of expands over time. So I think if you are going to let the granulation happen, then you want to make sure you have something there to sort of minimize the contracture. Although my only caveat to this is that you have to put the drops in several times a day,
Yeah.
right? So that's a little bit of the rate limiting because depending on the wound care that you're doing in that area or whether you're trying to keep it dry, like you have to constantly put the drops in to kind of keep it expanded. And that is a little bit tricky and that relies on the patient to do. So that is probably the rate limiting step of that and making sure that you take it out and it
Mm-hmm.
doesn't get too far into the ear is probably the biggest caveat that you have to keep in mind when you're using something like this. But anything that I think is expandable and kind of molds to the patient's ear canal is a great way to do it. So definitely worth giving a try if you are looking for something to put into the ear canal to prevent the stenosis or to minimize that risk from happening. But if it is going to happen or you start seeing the changes, then it's really important to sort of pull in your ENT colleagues or put something that's a little bit more pliable
Mm-hmm.
and leave it paid for longer. Some people use like the nose splints and they put it in
Mm-hmm.
and they try to do that just to kind of prevent that from happening over time because you can get the stenosis even later, right?
I
So even if
agree.
you leave it in for 10 days, the stenosis can happen way after that.
For sure. I think we see our grafts
Mhm.
contract for much longer after 10 days. So then, yes, if the earwick is removed, you're not preventing as much as that stenosis after it's removed. But I agree with you. I like this article a lot. I think it helps prevent blood on the tympanic membrane.
Yeah.
It kind of helps reduce some of the irritation you can get from surgery that's tracking down into that external auditory canal. So I thought this was nifty, but again, I've used a dental roll in the past and that's worked pretty well. Obviously, you want to be mindful of not leaving like inserted cotton
Oh,
too long
sure.
into orifices, but definitely, I think this is a fun article and worthwhile to check out.
If the earwig had something where like a string attached to it at the end, so
Yeah.
you can end up pulling it out at the end, that would be also pretty neat to see.
Yeah, I would use that a lot, I think.
Yes.
Okay, perfect.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendars out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
Our next article is Percutaneous Mesh Expansion for Closure of Surgical Defects on Legs by first author Ana Jimenez Sanchez and senior author Pedro Rodriguez Jimenez. Closing surgical defects on the lower legs remains one of the more challenging problems in derm surgery because of limited skin laxity, vascular compromise, and higher risk of delayed healing and infection. In this retrospective case series, the authors introduce a percutaneous mesh expansion technique as a simple, minimally invasive alternative for closing lower extremity defects. After tumor excision, if a tension-free primary closure is not possible, multiple small stab incisions are created in the surrounding skin using a 21 gauge needle or a number 11 blade. These microincisions increase tissue mobility, allowing the wound edges to advance sufficiently for direct closure using epidermal sutures alone. In the study, among 18 patients with 22 lower leg defects, averaging approximately 26 millimeters in diameter, this technique resulted in only 3 minor complications, including a hematoma, an infection, and partial dehiscence. Both physician-rated cosmetic and functional outcomes, as well as patient satisfaction, were high. This technique can provide an attractive alternative for more complex flaps or grafts, particularly in elderly patients or those with compromised lower extremity skin. Percutaneous mesh expansion is an inexpensive, relatively technically simple technique and preserves local tissue while avoiding more extensive reconstruction. Although larger comparative studies are still needed, this early experience suggests it is another valuable option in the reconstructive armamentarium for difficult, larger lower extremity defects. Dr. Lee, what do you think of this technique, and have you ever used something similar?
I have not. This is the first time I'm hearing of this for the lower extremities. I know this is used a lot by the plastics colleagues. They
Mm-hmm.
do it on their grafts. They can add additional meshing to expand it further. I know it's also used sometimes on the scalp from the plastics colleagues, but for lower leg defects, this is my first time seeing this, and I thought it was a very interesting technique because it is one of the tough areas that we all kind of encounter when you are on a lower leg defect and you really want to close it, but it just needs a little bit more tissue expansion. And what this allows you to do is sort of just poke all these holes. And just allows that extra, I think maybe like 20% that you need to sort of get
Mm-hmm.
the defect closed. Um, I do think the technique does require more time than you probably anticipate taking to do this. For something, you have to kind of the incisions pretty far out beyond the surgical site on both sides. So you need to anesthetize it, and you want to keep in mind how much anesthesia you're using for this. So you probably have to use like tumescent type anesthetics to sort of
Mm-hmm.
not go too high with your lidocaine dosage because you have to like numb a large area. So I think you have to sort of keep that in mind when you're doing this. You probably need to use some tumescent and anesthetics to go beyond the site if it's a large defect. And I think patient selection makes a big difference. Like you may not want to do this on someone on blood thinners,
Mm-hmm.
right? Because you're making, even though they are micro sort of holes that you're making, they are going to the subcutis. So patient selection, I think, is a big factor that you don't want to do this on someone who's on blood thinners. I was impressed that you don't see the scars, from
Mm-hmm.
the little holes that you made in that area. So from an aesthetic perspective, it's probably great that you can do that. And I do think it's going to be helpful in the elderly population where you don't want to do like a flap, but I would also probably be careful in patients who have very atrophic skin, right? Because even with these
Absolutely.
slits, they might end up, just coalescing together and making a bigger defect. So this is something I definitely think is worth trying. If you are sort of in this bind and you don't have the option of doing a flap and you feel like if you just get a little more tissue expansion, you can make these micro holes and it will give you that expansion on both sides for you to close it. And then they just use top stitches, which was, simple to do. So it seems to eliminate like the tension that you have, and you may not need to do deep sutures, but also doing them. And I would probably think that you don't want to undermine. So it's a different technique than what we're trained to because you are typically used to undermining and closing and putting deeps in. So you just have to keep in mind that you're not going to be doing the undermining and you don't really need to do deeps at all.
Yeah, I think your
Would you
point.
try this?
Yeah, I think your point about patient selection is so critical for our listeners because you don't want to do it in those patients that have very, very, like you said, atrophic skin where you're creating more channels that the skin can just tear through. A lot of times, you
Yeah,
throw a stitch even with your reverse cutting needle and it just completely tears through the patient's skin. So you want to be mindful of maybe perhaps not doing this technique in those patients. But I do like it potentially if it saves me from doing a keystone flap or something like that and gets the patient closed with a simple
right.
repair. So yeah, I think
Yes, for
patient
sure.
selection here would be critical. But maybe I'll try this and add this to my practice. But Just have to pick the right person.
I agree. I think you have to pick the right person, and then see how well it works. But I do think it'll move for sure once you kind of put those slits in. So it's a good option to consider.
Perfect. Our next article is Retroauricular Transposition Flaps, Considerations for Practical Application by first author Margaret Merriam and senior author Jesse Lewin. Reconstruction of anterior ear defects requires preserving not only cosmesis, but also the ear's function for patients who wear glasses, hearing aids, or earbuds. In this case series, the authors highlight the retroauricular transposition flap, also known as the pull-through or buttonhole flap, as a dependable reconstructive option for larger anterior auricular defects following Mohs. The flap utilizes the abundant tissue behind the ear, which is passed through a small cartilage window to resurface defects of the concha, antihelix, triangular fossa, or scapha. Because the flap remains attached by a muscular pedicle, it benefits from a robust blood supply while preserving the ear's natural contour. The authors reviewed 14 cases, most oftenly involving a basal cell carcinoma, with an average postoperative defect measuring 2.6 by 2.2 centimeters. All flaps remained viable, and there were no postoperative infections or bleeding complications, demonstrating the reliability of this technique. The retroauricular transposition flap is particularly useful for deeper anterior auricular defects where secondary intention healing or skin grafting could distort the ear or cause stricture. One technical consideration is avoiding tethering of the posterior ear in larger defects, particularly involving those for the superior antihelix. In select cases, allowing the posterior donor site to heal by second intent rather than closing it under tension can preserve the natural position of the ear. Overall, this flap provides excellent vascularity and maintains auricular architecture and allowing patients to return more quickly to normal function. Dr. Lee, I actually love using a retroauricular pull-through flap in my practice for mostly appropriate defects in my hands on the conchal bowl and antihelix. What are your thoughts with these types of flaps and what's your experience?
So I agree that this is a really nice review of the flap, and I think it really depends on what people are comfortable with. But in my hands, I do better with a full thickness skin graft. For me, when I do a retroauricular transposition flap, which is not a lot, I feel like they get a little bulkier.
Mm-hmm.
And I think the bulkiness sometimes just bothers me a little bit because in the long run, it's a little bit bulkier. And the tethering of the ear, it goes, the positioning sometimes can be slightly altered because, it's going to be tethered a bit to the back. So,
Pins the ear back slightly for
yeah,
those larger defects, for sure.
yeah. So I tend not to use this as much, but I do agree that in lieu of second intent, like you do want to either do a full thickness skin graft or the retroauricular transposition flap if you have a relatively large defect on the ear. The bulkiness, because you can't really trim it down either because it's sort of like you have the muscular pedicle to it. So it's more of like the appearance of it at the end that sometimes in my hands it gets a little bit bulky. And I feel like with a full thickness skin graft, I can control a little bit more the thickness and the thinness of it. So it's a great flap. I think it's, for some it works a lot better than for others. And, it really is the more you do, the more you get better at it. But always for me, it's a little bit bulky.
I agree. I think the authors really highlight that it needs to be a very deep defect where sometimes even where you're removing most of that cartilage or the tumor actually invades the cartilage, then in my hands, I do like using a bulkier flap because I feel like it provides that rigidity back when you lose that cartilage. So there's a little bit less of contracture or stenosis, similar to the article we talked about with stenosis of the external
Yes.
ear canal.
Yeah.
But I agree, for very thin defects, I 100% would also use more of a full thickness skin graft if a lot of the cartilage is preserved. But very interesting article, and I think always a great option to consider for select defects. Okay, our final Rapid Pearls article is Sliding Z-plasty for alignment of the vermilion border during vertical lip repairs by first author Jessica Padaneski and senior author Ian Maher. Repairing upper lip defects that cross the vermilion border remains one of the most technically demanding challenges in dermatologic surgery, where even subtle misalignment can affect both the appearance and oral function. In this technical report, the authors describe a refined approach to vertical lip closures that prioritizes restoration of function and improves scar camouflage. Traditionally, surgeons have focused on aligning the white line or vermilion border first. However, this can create undesirable outcomes such as a fat lip deformity, vermilion step-off, or even a trigon deformity. Building on an earlier technique, the authors instead recommend first aligning the wet line to restore normal lip function. They use a simplified sliding Z-plasty to realign the white line with the limbs of the Z-plasty placed just above and along the vermilion border where scars are naturally concealed. This modification is particularly valuable for patients with high-sloping vermilion borders undergoing vertical lip closure, where traditional alignment techniques may create excess tissue bulk or contour irregularities. By redirecting tension and hiding the Z-plasty within a natural cosmetic junction, this technique restores a smooth vermilion contour while minimizing visible scarring. Although the authors report experience in only 3 patients, this approach offers a thoughtful refinement that emphasizes both function and aesthetics, and is an important reminder that successful lip reconstruction depends on restoring this dynamic anatomy. Dr. Lee, how often do you utilize a Z-plasty at the vermilion border to prevent these types of trigon deformities?
So just to backtrack a little bit, so it's interesting because the lip, when you look at a patient sort of outcome perspective, anything, because it's the center and it's such a dynamic part of the face, having a good aesthetic outcome is extremely important for patients, especially on the lip area. The nose triumphs for sure, but the lip is a close second because any mismatch is so noticeable for the patient. Whenever there's a trigon deformity, then I do feel the Z-plasty is the best way to repair it. This is a neat way, and the pearl, I like it that you're using it sort of in advance to use it to sort of prevent this from happening from the get-go. But for a trigon, I feel like the Z-plasty is the best way to do it. If you end up having like a subtle misalignment of the vermilion border, I do think repair is extremely important. But I do think the timing of it makes a difference because you want to also give time for all the swelling and everything to subside down from the original surgical time, because if you end up doing it too prematurely, then you may overcorrect or do something where you improve it, but you haven't really fully corrected it because you're a little bit too premature in the timing of it. So some people have swelling that lasts longer. Some people, lose it quicker. So you just want to make sure that the patient is very close to sort of their baseline before you go ahead and make the correction. That's what I typically do because I always like to kind of see how things settle down before I do any type of correction. But this is a small, it's 3 patients, but again, they do kind of have this different approach to doing this, in advance. So I think this would work really well if you are trying to make sure that everything is matched up well.
Yeah, I think it's interesting that they talk specifically about patients with a very vertical or a high slope to their vermilion
Oh,
border.
yes, yeah, they did.
Definitely where, it is harder to reapproximate. In my fellowship, my training, I was always taught to, draw out the vermilion border before you inject any anesthetic. Make sure that is your key stitch, you're realigning that. But I think it's interesting they talk about that white line above the vermilion, and really that's what we should be focusing on rather than, or that wet line to restore the normal lip function rather than just vermilion border. So that's a takeaway I thought was interesting from this article and something I'll incorporate in my practice.
Yes, for sure. And I think the lip has so many different, you have the vermilion border, you also have the white roll, which is above it. So you want to sort of balance that out. And it also depends how some people have thinner lips and they lose sort of that fold or the white fold as they get older. So it really depends on, again, like the anatomy of the patient. But I still agree with you that you really want to make sure you mark everything. And if you do get a deformity or something later, that the Z-plasty often, it's usually with the trigon, when you lift it up, you can definitely lower it back down to where it's supposed to be with the Z-plasty.
Great. All right. Well, Dr. Lee, thank you so much for joining us and sharing your expertise on this month's highlights from dermatologic surgery. For more expert commentary on this month's journal articles, visit asds.net/DermSurgery-digest. We appreciate you spending time with us, and we look forward to having you back next month as we discuss more of the research shaping the future of derm surgery.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.